We're going to begin now to review the surgical specialties. We already had vignettes on orthopedics, but we're now going to include all of the other surgical specialties. The first one on the agenda is cardiothoracic, and we're going to begin with vignettes that are congenital heart disease. Let's read the first one. A 6-month-old baby has occasional stridor and episodes of respiratory distress with crowing respiration, during which he assumes a hyperextended position. The family has also noted mild difficulty in swallowing. Let me go back and analyze this vignette with you. Because if all this question had said was the respiratory distress that is described, the stridor and the crowing respiration and so on, the answer would have been that's probably tracheomalacia. But if in addition to those symptoms of something interfering with inspiration, you have also difficulty swallowing, then the answer is a vascular ring. Now, you might remember from embryology that at some point in embryological development we actually have 2 aortic arches which are connected by other vessels at the top. Eventually one of the 2 disappears and becomes another vessel, but it is possible for a child to be born with the 2 aortic arches still in place, and therefore, in fact, with a vascular ring, blood vessels all around forming a circle, and in the middle of that circle go the trachea and the esophagus. So it's not surprising that they could be impinged upon by those unyielding vascular structures. The barium swallow will be one of the first things done for the workup here, and it will show a typical extrinsic compression from the abnormal vessel. Bronchoscopy is also done. That confirms that there is segmental tracheal compression, and by the way, rules out the tracheomalacia, which, as we pointed out, would be very much in the differential diagnosis. Surgical repair is done then by dividing the smaller of the 2 aortic arches. Vignette number 2, it's a very generic thing. It in itself would not be an exam question, but it could be part of an exam question. A patient known to have a congenital heart defect with a hemodynamically non-significant shunt requires extensive dental work. The point of this vignette is that any morphological abnormality of the heart, whether congenital or acquired for that matter, is a weak point where bacteria can very easily set up shop. And so even though a patient may not need a repair because the defect, as explained here, is not hemodynamically significant, that individual needs to be protected with antibiotics for any situation in which a shower of bacteria would be likely to occur. And of course, dental work is a very good example of that. Now in the next few vignettes, we're going to be dealing with the congenital anomalies where there is a hole in the heart or otherwise a communication between the 2 sides of the circulation. Now these types of anomalies, as you know, are divided into 2 groups, the non-cyanotic and the cyanotic, and obviously the non-cyanotic are those where the abnormal flow is from left to right, whereas the cyanotic ones are those where the abnormal flow through the hole that shouldn't be there is from right to left. We're going to begin with the non-cyanotic. But before we go into the vignettes, let me give you a few general guidelines, because there are several things that all of the conditions that have a left to right shunt share. In all of them, there will be a murmur, because there is the noise being made by the blood that is going through the abnormal channels. In all of them, there will be increased pulmonary vascular markers, because the blood that should have gone from the left ventricle all the way to the tip of the toes before coming back and then sent to the lung are going through this short circuit and going through the lung time and time and time again. And perhaps as a corollary of the same phenomenon, The history can be elicited of frequent respiratory infections and colds and congestion and difficulty breathing and so on, which, depending on the severity of the shunt, may in fact be the predominant problem early on in life, or be a minor thing that is only elicited by history later on. And finally, as we implied from the definition in the first place, they share also the fact that there is no cyanosis. But depending on where the communication is, and therefore the pressures and the flow involved, we have pretty different clinical presentations. Let's read the first one. This is vignette number 3. During school physical exam, a 12-year-old girl is found to have a heart murmur. She is referred for further evaluation. An alert cardiology fellow recognizes that she indeed has a pulmonary flow systolic murmur, but he also notices that she has a fixed, split second heart sound. A history of frequent colds and upper respiratory infections is elicited. This one is an atrial septal defect. It's classic. The atrial septal defect obviously has the least of the shunts and anomaly and flow of any of these conditions, because the pressure of the atria is not nearly as high as it is in the ventricles. And so, not surprisingly, the children that have this condition can live for a good many years before it is even recognized. So it's not unusual that at age 12 was the first time when somebody recognized that there was a murmur, and the workup began. Then you have all of the expected to find, but there is one that is actually very classical, almost virtually diagnostic, and that is that fixed, split second heart sound. So when you read the vignette of a 12-year-old girl, somebody found a murmur, now there is a history of the frequent colds and upper respiratory infections, and there is a fixed, split second heart sound, you're dealing with an atrial septal defect. All right, now what do we do next? Let me give you an easy answer that is going to be applicable to a good many of the vignettes that follow. The workup of every morphological anomaly of the heart begins with an echocardiogram. This is true for congenital anomalies. This is true for acquired things as well. Valvular disease and things like that, echocardiogram is the first thing to do. Congenital problems, echocardiogram is the first thing to do. And in many instances, the only thing that needs to be done. Many times, echocardiogram can in fact provide all of the necessary information in a non-invasive way that then enables the surgical repair to be done. In rare cases, when there isn't enough information, of course, the older and more invasive cardiac catheterization may have to be used. All right, let's move on then to the next one. A 3-month-old boy is hospitalized for failure to thrive. He has a loud pansystolic heart murmur, best heard at the left sternal border. Chest X-ray shows increased pulmonary vascular markings. This one is a ventricular septal defect. There is a bigger flow, there is more of an anomaly, and not surprisingly, by age 3 months, the kid is already in trouble. Incidentally, let me call your attention to that expression there, failure to thrive. It's a classical thing denoting cardiopulmonary problems. Even though you might think, well, failure to thrive, which is another way of saying the kid isn't growing at the rate he's supposed to grow. You might think, well, that must be GI tract problems. Kid is not absorbing the food. It is actually a very common sign of cardiopulmonary problems. It essentially means the kid is so busy breathing that he doesn't have the time to eat. So when this child is suckling the breast or the bottle and trying to get the milk, he spends so much time surfacing for air, so to speak, breathing, that he doesn't drink very much. And then again, you see all of the other things. There is a loud pansystolic heart murmur. And then there are the increased pulmonary vascular markings, and your best bet here is a ventricular septal defect. You begin the workup with the echocardiogram, and then we proceed with a surgical repair. The surgical repair of these conditions, incidentally, is necessary because left alone, a significant left to right shunt eventually damages the lungs. All of that excessive flow through the pulmonary circulation leads eventually to increased pulmonary vascular resistance and eventually to permanent and irreversible damage to the lung. In some very extreme cases, even to a reversal of the flow, so that at some very late stage, cyanosis may in fact become part of the picture, because at that time the shunt becomes right to left instead of left to right. So the surgical repair would be the next step to be done in this child. But let me alert you to the fact that there is an exception. There is a variant of ventricular septal defect that has a different natural history. The one that we just read, the one with a loud murmur and so on, is a classical ventricular septal defect which is high up in the membranous part of the septum. Let's read vignette number 5. Because of a hard murmur, an otherwise asymptomatic 3-month-old baby is diagnosed with a small restrictive ventricular septal defect located low in the muscular septum. This particular variant of the ventricular septal defect can in fact close on its own. And therefore, if it is been diagnosed, which you of course would have to assume in this case means an echocardiogram was done, and that's how the diagnosis was made, then the answer in the exam would not be surgical repair, it would be watchful waiting. Now, during that watchful waiting, obviously the kid will have to be protected with antibiotics in any situation where a shower of bacteria might occur. That protection for subacute bacterial endocarditis is still needed. Let me add one more thing about ventricular septal defects. You may find in the description of one of these sort of a tantalizing little clue. It talks about a murmur. Both of these have it. And it might say, however, that murmur had not been heard on the day of birth. And this is not unusual, because when a baby is born, the baby who's just transitioning from fetal type circulation to adult type circulation still has a very high pulmonary resistance. And so even though the hole is there may not be much of a flow going from left to right, because the right isn't ready to receive the blood. And so it's not unusual that the murmur wasn't heard on day one and then becomes obvious later on once the flow is high. All right, let's move to the next one. We're now on vignette number 6. A 3-day-old premature baby has trouble feeding and pulmonary congestion. Physical exam shows bounding peripheral pulses and a continuous machinery-like heart murmur. Shortly thereafter, the baby goes into overt heart failure. The diagnosis on this one is easy. This is a patent ductus arteriosus. The kid is in trouble within a few days of birth. But the thing that makes it classical for you is that machinery-like murmur. There is nothing else for which we use that specific description. And it's one of those things where there is always that favorite word. See, whoever wrote this could have said there is a murmur that extends throughout systole and diastole. There is a murmur that is heard best in systole that persists throughout diastole. There would be a number of ways that you could describe this murmur, but the favorite expression is always the machinery-like murmur. So the instant you read machinery-like murmur, you know it's a patent ductus. You know also that the workup begins with the echocardiogram. But now what about the management? On this one, there is actually a choice, because the persistent open patent ductus arteriosus may be closed surgically or with any intervention such as embolization with coils, or it can be helped to undergo spontaneous closure with indomethacin. Now here are the general rules. like all general rules, peppered with exceptions. But the general rule is the indomethacin treatment works best in the premature baby. And the indomethacin treatment takes time to do the job and therefore cannot be used if the baby is in congestive failure. It's too late. If the baby is in congestive failure, a quicker solution, namely the surgical solution, is needed. So if we go back to the one we just read, it was a premature baby. That would have been a good candidate for indomethacin. But now we're told that shortly after the diagnosis, the baby goes into overt heart failure, too late for the indomethacin. And the answer then for this one, for the treatment, is surgical division of the patent ductus, or potentially embolization with coils. But now if we read vignette number 7, we'll see the other example. A premature baby girl has mild pulmonary congestion, signs of increased pulmonary blood flow on X-ray, a wide pulse pressure, and a precordial machinery-like murmur. She is not in congestive failure. Ideal candidate then for medical treatment with indomethacin. All right, let's move on now to the cyanotic conditions. And the cyanotic conditions also have several things that they share. All of them, of course, represent a right to left shunt, so in all of them there is cyanosis. Because there is a flow that is abnormal, all of them will have a hard murmur. And now in all of them, you're going to find the opposite findings in the lung than we had for the previous group. Because now the blood is being diverted away from the pulmonary circulation via the shunt back into the systemic circulation. There will be decreased pulmonary vascular markings on the X-rays. Now, if you remember your medical school introduction to the topic, you might recall that one of the mnemonics that was used to help you remember the cyanotic congenital heart conditions was that there are 5 of them, and they all begin with the letter T. Tetralogy of Fallot, transposition of the great vessels, truncus arteriosus, total anomalous pulmonary venous connection, and tricuspid atresia. But I do not intend to review all 5. It turns out that 3 of the 5 are pretty rare. Only 2 of them are relatively common, and therefore I think those 2 have a higher likelihood of being on the exam. The most common of all 5 of them is tetralogy of Fallot. And the next most common is a transposition of the great vessels. But these 2 can be distinguished pretty easily on the exam, because the tetralogy of Fallot, the most common one, even though it is crippling for the babies that have it, it allows those babies to grow up to be 5 and 6 and 7 and 8 years old. They are pitiful little creatures. They cannot keep up with their classmates. They're blue all the time, but they can grow to that age. Whereas a baby that is born with transposition of the great vessels, if that baby isn't fixed within a few days, that baby dies. Which means then that if we find a question on the exam of a cyanotic baby who's 5 or 6 or 7 years old, it's probably tetralogy of Fallot. Let's read the vignette. This is vignette number 8. A 6-year-old boy is brought to the U.S. by his new adoptive parents from an orphanage in Eastern Europe. The boy is small for his age and has a bluish hue in the lips and tips of his fingers. He has clubbing and spells of cyanosis relieved with squatting. He has a systolic ejection murmur in the left third intercostal space. Chest X-ray shows a small heart and diminished pulmonary vascular markings. EKG shows right ventricular hypertrophy. That's the complete description of a baby with tetralogy of Fallot. But again, you're able to recognize it simply by the fact that this cyanotic baby has grown to be 6 years old. Incidentally, there is no particular increased incidence of this congenital defect in Eastern Europe. That little bit is there, as I have explained to you for other vignettes in the past, to somehow justify how come for 6 years this poor kid has been huffing and puffing and blue in the face and nobody's done anything about it. So when an exam question gives you a chronically neglected health condition, it frequently gives you the excuse, well, in this case, the kid had no parents, there was no access to health care, whatever. All right, let me remind you again. You would begin the workup here with an echocardiogram, and then we would proceed to the repair. And on the other hand, I don't have a vignette for it, but on the other hand, if you were to have a vignette that says a little baby is born with cyanosis, and he's 2 days old, and is, very, very sick indeed, and, looks like he's going to die, there's a good chance that that one would be transposition of the great vessels. All right, now we move to acquired heart disease. Now, this is a surgical review, so we're not going to talk about the medical aspects of these, but primarily we're going to concentrate on when and where is surgery indicated. Vignette number 9. A 72-year-old man has a history of angina and exertional syncopal episodes. He has a harsh mid-systolic heart murmur, best heard at the second intercostal space and along the left sternal border. Now, this is aortic stenosis. You should be able to recognize it. The murmur is during systole. It is best heard at the base. That should actually be the second intercostal space on the right, but the radiation of a murmur is the left sternal border. All right, when do we need surgical repair here? Well, first of all, we would begin the workup with an echocardiogram. Remember, this is a morphological anomaly. And actually, the echocardiogram gives a wealth of information. Not only does it show the damaged valve, it can give us a pretty good idea of flow and gradients and things like that. The surgical valvular replacement is indicated if there is a gradient of more than 50 millimeters of mercury across that valve, or at the first indication of either congestive heart failure, angina, or syncope. So this vignette, in fact, as described, angina and syncopal episodes, is a person that needs the operation. Now, the aortic valve cannot be repaired once it has been damaged, and so the operation we're talking about is a valvular replacement, a prosthetic valve. Vignette number 10. A 72-year-old man has been known for years to have a wide pulse pressure and a blowing, high-pitched, diastolic heart murmur, best heard at the second intercostal space and along the left lower sternal border, with the patient in full expiration. He has had periodic echocardiograms, and in the most recent one, there is evidence of beginning left ventricular dilatation. That vignette is chronic aortic insufficiency, and the vignette is giving you the indication for the aortic valve replacement, which is that very last line. As soon as we see that ventricular dilatation is beginning to occur, that's the time to intervene. Let me back up for a second. How were you able to identify that this is aortic insufficiency? Well, again, the murmur is best heard at the base, but in this case, obviously, the murmur is when the blood goes back into the ventricle from the aorta, and therefore it is a diastolic murmur. But there is also that classical finding of the wide pulse pressure. The ventricle ejects the blood and generates systolic pressure, but instead of that blood remaining now in the vessels because of a closed valve, and therefore having a pretty high diastolic pressure, that blood goes back into the ventricle because the valve isn't closing, and therefore the diastolic pressure is way down. All right, so here again is an indication for aortic valve replacement. Vignette number 11. A 26-year-old drug-addicted man develops congestive heart failure over a short period of a few days. He has a loud diastolic murmur at the right second intercostal space. A physical exam done a few weeks ago, when he had attempted to enroll in a detoxification program, was completely normal. Now, this is a variant of aortic insufficiency that you cannot live with for a long period of time like the previous one. The previous one was chronic aortic insufficiency. This one is acute aortic insufficiency. It is due to endocarditis, and it's one of the many risks that the drug-addicted person suffers. Now, I'm aware of the fact that when you inject something contaminated into your veins, the first set of valves that gets those bugs are the ones on the right side of the heart. But those are less critical, those valves. In other words, damage done to the tricuspid or damage done to the pulmonary valve doesn't have the same impact on your overall health as damage has done to the aortic valve. And so this description where the patient has gone into congestive heart failure in a matter of a few days, this is pretty classical for the individual who was so unlucky that where the bugs set up shop and destroyed the valve was in the aortic valve. Now this individual needs emergency valve replacement. Of course, also intravenous antibiotics and then continued antibiotics for a long, long time. All right, let's move on to the mitral valve. We're on vignette number 12. A 35-year-old lady has dyspnea on her exertion, orthopnea, paroxysmal nocturnal dyspnea, cough, and hemoptysis. She has had these progressive symptoms for about 5 years. She looks thin and cachectic, has atrial fibrillation, and a low-pitched, rumbling, diastolic, apical heart murmur. At age 15, she had rheumatic fever. Classical description for mitral stenosis. Mitral stenosis is due primarily to rheumatic fever, which is always good many, many years in the past. Anytime that you hear that the murmur is best heard at the apex, an apical murmur, you know that's coming from the mitral or the tricuspid valve. And if it is diastolic, well then the problem is stenosis rather than insufficiency. So what do we do here? You begin the workup with the echocardiogram. The indication for intervention here is not one of those that is one number or one single event. It's essentially when the patient is sick and tired of the problems that she's having. So this is a gradual thing. This is a disease with a gradual progression. She's had these things already for 5 years. But if she gets to the point where she's sick and tired of getting up at night all the time, she cannot breathe, she's coughing, it's time to do something. And we would prefer, if at all possible, to repair the mitral valve rather than replace it. Now, if we cannot repair it, we certainly can replace it, but we prefer the repair. So if the problem is mitral stenosis, we would hope to be able to do a mitral commissurotomy, open up that valve that now doesn't open. Vignette number 13, a 55-year-old lady has been known for years to have mitral valve prolapse. She now has developed exertional dyspnea, orthopnea, and atrial fibrillation. She has an apical, high-pitched, holosystolic heart murmur that radiates to the axilla and back. This one is mitral regurgitation. Again, the murmur is apical, but is during systole. And the most common reason, I might add, for mitral regurgitation is mitral valve prolapse, so it's all there. Like the previous vignette, we would begin the workup with an echocardiogram. Like in the previous vignette, we don't have a single well-defined point that says this is the time to intervene surgically. The lady is having problems, she's sick and tired of her crippled condition, time to do something. And like in the previous one, we would prefer to repair the existing native valve rather than to put a prosthesis. In this case, the repair would be an annuloplasty. The leaflets no longer meet in the middle and therefore cannot close the opening. And by making the attachment to the leaflets, the annulus, smaller, we put those leaflets closer to one another. So an annuloplasty would be the preferred operation. If it cannot be done, we can put the prosthesis. All right, let's move now to coronary disease. Vignette number 14. A 55-year-old man has progressive, unstable, disabling angina that does not respond to medical management. His father and two older brothers died of heart attacks before the age of 50. The patient stopped smoking 20 years ago, but still has a sedentary lifestyle, is a bit overweight, has type 2 diabetes mellitus, and has high cholesterol. But this vignette is a heart attack waiting to happen. I mean, this individual, first of all, he did choose the wrong family to begin with. You know, the genes that he inherited are not to his benefit. And his lifestyle isn't helping either. This man has a problem. But as you know, angina is typically handled medically. We don't operate at the first indication that somebody has angina. But intervention is indicated on the first line of this vignette. Progressive, unstable, disabling angina, no longer responding to medical management. That's the indication to do something. Now, what do we do? Well, essentially, we have to evaluate to see if this patient is a candidate for coronary revascularization. Eventually, ultimately, that will be done with cardiac catheterization. So we can look at his coronaries, see how many of the vessels have occlusions and how big those occlusions are, and how good is the vessel distal to that, so that we can ascertain is this individual a candidate or not, and if he is a candidate, what can we do about it? And this will be illustrated in the next vignette. So if you were given this one on the exam as I just read it, your answer is this man needs a cardiac catheterization. Let's move now to vignette 15. A 55-year-old man has progressive, unstable, disabling angina that does not respond to medical management. His father and two older brothers died of heart attacks before the age of 50. The patient stopped smoking 20 years ago, but still has a sedentary lifestyle, is a bit overweight, has type 2 diabetes mellitus, has high cholesterol. Cardiac catheterization demonstrates 70% occlusion of 3 coronary arteries with good distal vessels, and his left ventricular ejection fraction is 65%. I gave you this particular vignette to actually give you the ideal candidate for coronary bypass surgery, for the famous CABG, coronary artery graft bypass. When we have 70% or more stenosis on coronaries, those coronaries need something done. If a man had only one vessel and he was not the critical anterior descending, then he might be a candidate, in fact, for balloon dilatation and stent, angioplasty and stent. But if he's got several vessels, I gave you 3 on this vignette, most people would agree that surgical approach is better. The surgical approach would use then the internal mammary artery for the most critical of the vessels and the saphenous vein bypass grafts for the others. But in doing something aggressive about coronary disease, we also need to be reassured that the damage that has been done to the myocardium is not so extensive and irreversible that there is no point in bringing new blood supply to a dead muscle that can no longer work. So we always look also at that ejection fraction. And this man has an excellent one. In fact, this is almost better than normal. So this individual, therefore, again, is an ideal candidate. Good function in his ventricle, 3 vessels at a critical degree of stenosis, good vessels beyond that grafts can be hooked up to. This man needs a coronary bypass. The next 2 vignettes show a little bit of application of basic science to clinical situations. They are examples of those questions that sometimes appear on the exam as a bridge between the basic sciences and the clinical sciences, as a bridge between step 1 and step 2 of the USMLE. Vignette number 60. A post-operative patient who underwent open heart surgery is determined to have a cardiac index of 1.7 liters per minute per square meter and the left ventricular end diastolic pressure of 3 millimeters of mercury. What you are giving here, in fact, are 2 numbers, 2 physiological parameters. But they are given to you in the context of an everyday, very common clinical situation. This kind of diagnostic dilemma happens every day across the nation in the coronary care units in patients who just had open heart surgery. The first thing we should be able to identify here is that this man has a very low cardiac index. You might remember that an average size adult typically has a cardiac output of about 5 liters per minute. The cardiac index makes the cardiac output as a function of body surface. An average size adult is about 1.7 square meters, so expressed not by the cardiac output of the whole patient, but the cardiac output per square meter of body surface, you still see then that it ought to be 3 or 3.5 or, a little more liters per minute. Well, if it is 1.7, it's obviously low. Okay, so the first diagnostic information we get from this vignette is there is a low cardiac output. But the next question, if this is a post-operative patient, he just had open heart surgery done, is this due to ventricular failure? Is it to inability of the ventricle to propel the blood, or is it due to insufficient volume within the vascular tree? And therefore, the perennial therapeutic dilemma in this case is, do we give more fluid to the patient, or do we direct our efforts in the way of ionotropic drugs and ventricular support devices and so on? So then we look at the end diastolic pressure. If it is high, it would mean that ventricle cannot push out the blood that's getting to it. If it is low, it means we have room for more fluid. In this case, it is low. So the therapeutic decision on this post-operative patient would be, let's give him more fluids. That's the answer to the exam. Vignette number 17. Cardiac catheterization shows a square root sign, an equalization of pressures, right atrial, right ventricular diastolic, pulmonary artery diastolic, pulmonary capillary wedge, and left ventricular diastolic, in a patient with dyspnea on exertion, hepatomegaly, and ascites. These are pretty classical findings for chronic constrictive pericarditis. And a surgical repair would be indicated there. Now we move to the lung. And in fact, I have reason to believe, given its importance in the practice of medicine in this country, that there will be 1 or more questions in your exam that will deal with cancer of the lung. There is no other cancer that kills more people in this country than cancer of the lung. It turns out that the workup of cancer of the lung, though, is very complicated. Now, the classical vignette begins with an individual who, for some reason, gets a chest X-ray and a shadow is found. So the beginning of the exam question on cancer of the lung will be somebody, typically an older person, chronic smoker, who because of chronic cough or hemoptysis or whatever, gets a chest x-ray, or maybe just gets a chest x-ray, pre-employment, physical, whatever. And on that chest x-ray there is either a little area that is not aerated, or more classically, in fact, a circle there, a coin lesion, the shadow of a growth. Now, the workup for cancer of the lung, there are a couple of things that can be done that are non-invasive. We can do sputum cytology and sometimes get an answer, although sputum cytology is notorious for not being highly productive. But we can get that answer in a non-invasive way. But if that doesn't give you an answer, everything else that we do to diagnose cancer of the lung is invasive and expensive and risky. For a central lesion, we have to do bronchoscopy and biopsies. For a peripheral lesion, we have to do transthoracic needle biopsies. And if either of these are insufficient and do not produce a necessary diagnosis, we may have to do a thoracotomy and a wedge resection of the area that is suspicious. Now that chain, though, of progression, how far up that chain do we go to establish a diagnosis, is in turn modified by two other factors. Because if we make this diagnosis, we don't make it just for the intellectual exercise. We're going to make it so we can then proceed with treatment. So one modifying factor may be, would we be able to provide the appropriate treatment if the diagnosis was made? And if it is a central lesion, a central cancer of the lung, which is a non-small cell, that is a central cancer of the lung, that is either a squamous cell carcinoma, adenocarcinoma, or large cell carcinoma, what the patient would need is a pneumonectomy. And the pneumonectomy cannot be done if the pulmonary function is so compromised to begin with that the patient then could not survive or be happy with only one lung left. So depending on the presentation of the case, if the case suggests from the background that the patient has chronic obstructive pulmonary disease, is already huffing and puffing and short of breath, and then he shows up with this central lesion for which a pneumonectomy would be needed, if we can establish that he would not be able to tolerate a pneumonectomy, they were not really justified on being too aggressive in obtaining the diagnosis, because the diagnosis will not lead to anything. And so in some cases then it will be pulmonary function studies that we will need to do first. Let me give you sort of a shortcut for these. Again, I hope you realize these are oversimplifications to be able to review for the exam in an abbreviated period of time. But the bottom line is that once a pneumonectomy has been done, that patient should still have an FEV1 of at least 800 milliliters. FEV1, if you remember, is the forced expiratory volume at 1 second. So if we are evaluating this particular facet of the patient's workup, we would do pulmonary function studies, find out what is the FEV1 now that both lungs are in place. Then we would do a ventilation perfusion scan to learn what percentage of that total function comes from each lung. And then we go through a little mathematics in our heads. If we were to remove that lung that contributes X percentage to the pulmonary function, and the calculation says we would be left with less than 800, we cannot operate on that patient. You cannot have a pneumonectomy. And then there is no point in doing a wedge resection for diagnosis, perhaps not even a point in being too invasive, even if it's only the bronchoscopy or the percutaneous. But we're not through yet. This is a complicated thing, I told you at the outset. There is another limiting factor. There is in turn no point on doing that pneumonectomy for the central lesion or lobectomy for peripheral lesion, if there is no hope that that will cure the patient. And so part of evaluation of a patient with cancer of the lung, right from the beginning of the workup, is how extensive is this cancer of the lung. If it already has metastasis on the other lung, if it already has liver metastasis, if it already has mediastinal metastasis at the level of the carina, then this patient cannot be cured. And if a patient cannot be cured, we don't do pneumonectomies or lobectomies for palliation. All right, let's look at the interplay of these factors. But before I do that, let me point out to you, there is one question actually that has a very easy answer, because we can give an answer before all of those complicated things have to be thought about. Let's read the next vignette. Vignette number 18. On a routine pre-employment physical examination, a chest X-ray is done on a 45-year-old chronic smoker. A coin lesion is found in the upper lobe of the right lung. The concern, of course, is this thing a cancer of the lung? But before we go into any of the other considerations that I just talked about, the first thing we want to do here is see if there is a recent chest X-ray of this gentleman from perhaps 1 or 2 years ago, and we see if that same lesion is there. Because if that very same coin lesion was there on an X-ray 1 or 2 years ago, this is not cancer of the lung. Cancer of the lung has such a predictable, relentless, aggressive growth pattern that if it was there 2 years ago or a year ago and the patient hasn't died and still has the same lesion, then that's a benign lesion. And all you would do for that patient is follow up. You would continue to take X-rays from time to time in case that thing begins to grow and now it's no longer a stable thing, but you would not go into any further workup. All right, let's now begin to look at the difficult ones. Vignette number 19. A 65-year-old man with a 40-pack-year history of smoking gets a chest X-ray because of persistent cough. A peripheral 2 cm coin lesion is found in the right lung. A chest X-ray taken 2 years ago had been normal. Now we have a very high likelihood that this is cancer. Above age 50, coin lesions have about an 80% chance of being malignant. You add to that the fact that this is a chronic smoker, and it's even higher. You add to that the fact that this lesion wasn't there 2 years ago. This is virtually certain to be a cancer of the lung. So this gentleman needs some beginning of a workup. Well, there is a good rule for the exam, that if there is something we can do that is non-invasive, that would be a good way to begin. And in fact, there are 2 non-invasive things we could do. Sputum cytology and the CT scan that includes not only the chest but the upper abdomen as well. The sputum cytology might, I'm saying might rather than will, okay, might give us a diagnosis. And the CT scan may, in fact, provide information about extent that might persuade us not to continue with the workup. Because if that CT scan shows mets on the other lung, shows big nodes by the carina, or shows liver mets, then there is no point in going much further. I realize, and I have to remind you again, that the yield for the sputum cytology is low. There are some clinicians who don't bother doing it on the grounds that, it's going to be negative most of the time, so why bother? But it's a possibility if it appears on the exam as an option. Sputum cytology and CT scan, that would be a good way to begin this workup. If not, if that option isn't available, and this is a peripheral coin lesion, then it would have to be a percutaneous biopsy. If it had been a central lesion, it would have been bronchoscopy and biopsy. All right, let's move on to another one. Vignette number 20. A 66-year-old man with a 40-pack-year history of smoking gets a chest X-ray because of persistent cough. A peripheral 2 cm coin lesion is found in the right lung. A chest X-ray taken 2 years ago had been normal. CT scan shows no calcifications in the mass. Let me stop here for a second and alert you to the significance of these. A calcified mass in the lung is more likely to be benign, and non-calcified mass is more likely to be malignant. So we have another tidbit here that says this is probably cancer. His age, the smoking history, the fact that that thing wasn't there 2 years ago, and now we add it's not calcified. Let me keep reading. That CT scan shows no liver mets and no enlarged peribronchial or peritracheal lymph nodes. Sputum cytology, bronchoscopy, and percutaneous needle biopsy have not been diagnostic. The man has good pulmonary function and is otherwise in good health. Well, here we have an individual with an extremely high likelihood that this lesion we're looking at in the X-ray is a cancer. Number 2, a pretty good chance that we could cure him, because the CAT scan shows no extent that would make it incurable, and no limitation to our ability to do the needed operation. This is a peripheral lesion, so it could be done with a lobectomy. Even if it were a little less peripheral than we thought and needed a pneumonectomy, the man, we're told, has good pulmonary function, is in good health. So this is a good example where we've tried all of the diagnostic steps shy of the ultimate one, which is the thoracotomy and wedge resection. Well, that ultimate one is indicated. So the next move on this gentleman is thoracotomy and wedge resection. Let's move to the next one, vignette number 21. A 72-year-old chronic smoker with severe COPD. Pay attention, we're being alerted here. Pulmonary function might be the limiting factor, right? So a 72-year-old chronic smoker with severe COPD is found to have a central hilar mass on chest X-ray. Sputum cytology establishes a diagnosis of squamous cell carcinoma of the lung. If this is as far as the vignette went, you already have a diagnosis with a non-invasive test, and you've been told that the man is a chronic smoker with severe chronic obstructive pulmonary disease. I think what you would want to do is evaluate pulmonary function, because he would need a pneumonectomy. It's a central lesion. And we're being told, it looks iffy. Well, indeed, this was done in the vignette. His FEV1 is 1100. And a ventilation perfusion scan shows that 60% of his pulmonary function comes from the affected lung. So if you were to do a pneumonectomy on this gentleman, you would take away 60% of 1100. You would be left like 440 FEV1, and you need 800 to be a happy camper. So this man cannot have a pneumonectomy. No point now then in spending more money doing a CT scan to see how extensive the tumor is, perhaps going beyond to establish the extent of the tumor. Sometimes if the CT scan doesn't give all the necessary information we need, there's a little operation we sometimes do at the base of the neck that we call a cervical mediastinal exploration, where we get lymph nodes from around the carina to see if they are full of cancer. None of that would be indicated here. In fact, this is the end of the workup. All we can do for this gentleman is palliative treatment, which would be radiation and chemotherapy. Let's move on to the next one. Vignette number 22, a 62-year-old chronic smoker has an episode of hemoptysis. Chest X-ray shows a central hilar mass. Bronchoscopy and biopsy establish a diagnosis of squamous cell carcinoma of the lung. His FEV1 is 2200, and a ventilation perfusion scan shows that 30% of his pulmonary function comes from the affected lung. So if we took out that lung that has a cancer, we would remove 30% of 2200, hey, we would be left with plenty. Certainly a lot more than the minimum 800. So yes, a pneumonectomy could be done in this gentleman. So the next step here is it worthwhile doing it? And so if it hasn't been done, the next thing this man needs is a CT scan that includes the liver. And if that didn't give all of the information we needed, he might be a candidate for that cervical mediastinal exploration after the CT scan, so we can eventually proceed with an pneumonectomy. All right, vignette number 23. A 33-year-old woman is undergoing a diagnostic workup because she appears to have Cushing's syndrome. Chest X-ray shows a central 3 cm round mass on the right lung. Bronchoscopy and biopsy confirm a diagnosis of small cell carcinoma of the lung. I mentioned this already, but if you didn't quite catch it at the time, you might begin to think now, well, this is a central lesion, it would need a pneumonectomy, let me evaluate pulmonary function. You don't need to do any of that. Let me remind you again that surgery is the indicated treatment for the non-small cell cancers of the lung. For small cell cancer of the lung, we go directly to radiation and chemotherapy. That is the preferred mode of treatment. And so we don't need to evaluate pulmonary function study. We're not contemplating a pneumonectomy. We don't even need to know how extensive a tumor is from the viewpoint of can we resect it or not. We may want to find out how it is so we see how well she responds to the therapy and so on, but evaluation for a pneumonectomy is not part of the picture here. I trust, by the way, that you saw the connection between the Cushing's syndrome and this tumor. Small cell cancer of the lung, as you know, is notorious for its propensity to make hormones. It's one of those frequently responsible for the paraneoplastic syndrome, and that's what we have here. Okay, now we're moving on to peripheral vascular. And for the most part, peripheral vascular surgeons deal with the manifestations and the complications of arteriosclerotic occlusive disease, although occasionally the problem will be embolization, and we're going to have vignettes for both of these. Now, arteriosclerotic occlusive disease, as you know, is a systemic disease. It affects every blood vessel in the body. It's typically an elderly male, high cholesterol, type 2 diabetes, sedentary, eats a lot of fat. But the area of the disease that we address surgically is the one that's giving problems at the time. And so we sometimes address cerebrovascular problems or coronary disease or aneurysms of the abdominal aorta or claudication of the lower extremity. But interestingly enough, the upper extremity is seldom involved. It is rare that we have to do surgery to improve the circulation to the arms in a patient that has arteriosclerotic occlusive disease. But there is one exception. That one exception is a condition that is actually rare. It's not a common condition, but it's fascinating. It's so fascinating. I mean, what happens there physiologically is such a thrilling thing that this is a favorite of medical school professors and therefore a favorite to be on exams. Let's read it. A 54-year-old right-handed laborer notices coldness and tingling in his left hand as well as pain in the forearm when he does strenuous work. What really concerned him, though, is that in the last few episodes, he also experienced transitory vertigo, blurred vision, and difficulty articulating his speech. Let me stop there. And let me go back to reading this vignette one piece at a time. If you had a question on the exam that only said, when an individual uses the arm complains in some way, your best bet, in fact, would be a thoracic outlet syndrome. One of those individuals that has a cervical rib or a big scaly muscle that's pushing on the arteries and nerves and so on. But if you have a combination The arm complains when it is exercised, and the posterior part of the brain complains. Then what you have is the subclavian steal syndrome. What's happening in this individual is there is a arteriosclerotic plaque at the origin of the subclavian artery before the takeoff for the vertebra. This narrow lumen still enables enough blood to reach the arm for normal function of the arm. But when the arm is exercised and requires more blood, cannot get it through the narrow area, it siphons it away from the brain by reversing the flow in the vertebral artery. Of course, the brain is getting blood through 4 vessels, the 2 carotids and the 2 vertebrates. And so in this area where the problem exists, that vertebral reverses flow, and the flow that's going to the brain via the 2 carotids and the other vertebral is now being stolen away by the arm, away from the brain. And thus the name of the disease, the subclavian steal syndrome. And you can demonstrate that this is happening by doing an arteriogram that shows the reversal of flow. And that's the last line on this vignette. Angiogram demonstrates retrograde flow through the vertebral artery. All right, this is subclavian steal syndrome. Again, you should be able to recognize it. It's a combination of claudication of the arm with CNS symptoms referable to the back part of the head, equilibrium, cerebellum, visual cortex. Okay. And then we do the angiogram, we demonstrate the reverse flow, and then we can bypass the area. We can put a bypass graft that brings blood to the arm without having to steal it from the brain.